Good morning, ladies, and welcome back from your break. Thank you for being so prompt and getting back in here for what I'm very excited will be a fabulous panel session. My name is Katelyn Brown. I am a global lead client partner at Deloitte, and I'm also an IWF UK member. Woo! I am delighted to be your moderator for this session. Mental health sits at the intersection of everything we care about as a society: education, employment, justice, and human dignity. And yet, it's estimated that nearly a quarter of the world's population is living with mental health issues, be it depression, trauma, anxiety, or neurodevelopmental disorders. So the big question is, how can we ensure that everyone has access to the care they need? We are fortunate to have three fabulous leaders who have dedicated their careers to answering this question. Rebekah Cresswell is Chief Executive Officer of the Priory Group, one of the UK's largest independent providers of mental health services. She is a nurse by training and has over 30 years' experience in health and social care. She spent more than 14 years in the NHS, most recently as Assistant Director of Clinical Quality and Patient Safety. Welcome, Rebekah. Dr. Mary Docherty is National Clinical Director for Adult Mental Health at NHS England, where she shapes policy and practice across the entire system. She's held many policy roles throughout the NHS, always with a focus on tackling inequalities and closing the gaps in mental health care for people who need it most. Welcome, Mary. Dr. Mina Fazel is Professor and Chair of Child and Adolescent Psychiatry at the University of Oxford. Her globally recognized research has centered on improving mental health interventions for children and adolescents, as well as the well-being of refugee children. She also leads the Cresswell Student Survey, an initiative focused on student health and well-being. Welcome, Mina. Before we begin, I'd like to thank you for joining this session. And it is a vital discussion that we do not discuss as much as we should. As we did with our first panel, what I'd like for you to do is submit your questions through the app, and we'll try to get to as many of those questions toward the end. Globally, a quarter of the population will at some point in their lives experience a mental health challenge. Rebekah, you've seen this in the UK, both from an NHS perspective, as a nurse, and now as an NHS partner. Why isn't this more of a priority, not just in the NHS, but around the world?
Thank you. Very good question. I think we're very visual, aren't we, as humans? If we saw somebody with a big gaping wound in their side, somebody go, oh my goodness, this person needs help, or so with mental health, when somebody's got a wound in their mind, their soul, how they're feeling, it's hard for us to relate. And it gets more complex than that, doesn't it? Because of people, it can be very complex in terms of enduring. There's some misconceptions that people should just be able to pull themselves out of it, or that they might be weak if they can't do that. And you know, these misconceptions all end up clouding. If you overlay culture on that, some of the cultures, I grew up in Thailand, don't even recognize mental health as a problem. Now they do, but you know, sort of 50 years ago, it wouldn't be. So I think it's a very complex thing for leaders to grab hold of. So when you extrapolate that out globally, you can't address mental health issues without addressing some fundamental issues in society, and then it becomes very hard for politicians. And sometimes you know, really looking after people can butt up against some of the business and economic things that countries are trying to achieve. So I just think it gets messy. So, yeah.
Thank you, Rebekah. Half of all chronic mental health conditions emerge before the age of 14. 3/4 by the age of 25. Mina, your research shows that early intervention saves lives. What does effective early intervention look like, and how can we see it more often?
Yes, thank you. I think that we have a choice to make often. So a lot of what's happening in mental health is us adopting a somewhat firefighting approach. We see distress in front of us. We have to pivot our services to deal with that. Of course we do. But the reality is that if we really want to start making a big difference, we have to think about problems in the same way that we learnt about physical health problems. Clean water, vaccinations have saved an extraordinary number of lives. What's the equivalent when it comes to mental health? And we need to really be thinking really clearly about that and be brave enough to invest in that, because that's really not part of a short-term political agenda. That's a long-term human societal agenda. I thought I'd just ask quickly, like, who currently lives in the city where they went to high school in? Thank you. So I think the reason I ask that is because I think that speaks to a lot of the issues that I'm quite interested in. That we really, thinking about the theme of transformation to tradition, I feel like I'm going down the tradition road here, but I feel that we need to think about the massive shifts that are taking place in society, and we need to be understanding about the role of belonging. What are the things that we can do to support our communities, support our societies, and work more on? So I run this big survey, and the head of Children's Services in Liverpool came to me a few years ago and said, Mina, we'd like you to come and work with us. And I said to him, well, do you have a 1-year perspective, a 5-year perspective, or a 20-year perspective? Fortunately for him, he said 20 years. Otherwise, I just am not interested, because actually these are complex issues. We actually need to have a committed approach to it. And so working with this long-term lens, being brave enough to adopt that lens is, I think, what we need.
Thank you, Mina. Mary, the NHS is working on this now, focusing on youth and community mental health teams, as well as 24/7 emergency centers. Can you tell us some of the specific initiatives underway in addressing the UK's mental health challenges as part of the NHS's 10-year health plan?
Yes, no problem. I might leave some detail about the schools to the lady on my left who's got far more experience in that. But if I give sort of a couple of headlines really as to what key areas of policy in England are at the moment. I think the headline is that we're trying to bring continuity back into our care pathways. That's really an important and sort of central tenet of lots of the kind of upcoming transformation. And what I mean by that is there's a reasonable amount of evidence that says one of the key things that makes a difference, not necessarily totally determines the outcome, but makes a difference, is whether you see the same person, you build a relationship with them, that you're able to trust and develop a therapeutic relationship with someone. The way that specialist services have evolved in England, in some ways it's incredible. You know, we've got perinatal services, first episode psychosis services, home treatment teams, crisis services. But the challenge of that is that the experience of the person on the other end, who's at their worst or lowest point, is that they're passed between different people. One of the really challenging things that we have in England, and we were real pioneers in this, was the development of our crisis resolution and home treatment teams. These are teams that go to your home. They're an alternative to hospital. They're when you're really sick. But the challenge is that you might be with sort of a community team. You get more unwell. You have to go and see someone else. And that's awful, you know, when you are at your worst point. So what we're trying to do through this, you might hear about neighbourhood mental health centres. We're trying to reorganise, bringing that crisis function back into kind of core services, so that increasingly you have kind of the same team, the same clinician, who follow you how you are doing in terms of your mental health, whether you're really unwell, you might need a short stay in hospital, or whether you're doing a little bit better. So that's kind of one of the key areas. The other thing that's worth sort of mentioning, it might be something to talk about a bit more, because I think this has hit the press because it's quite a good gobbet. We're building mental health emergency departments. Now, the context in England is that we already have a lot of mental health in emergency departments. We've worked for over a decade to establish what we call liaison services, which is psychiatrists and nurses based in emergency departments, recognizing that lots of mental health presents with a concurrent physical health problem. So we've got a really solid infrastructure with liaison psychiatry. It was a policy initiative that really sort of got some teeth about 5-6 years ago. But there's a recognition that if you need to access help in an environment that feels safe and in a place where you can rapidly talk to someone about what's going on for you, is that a really busy ED is sometimes not the right place. So the government is committed to rolling out 85 of these new mental health emergency departments, ideally co-located within the physical health hospital. Probably will be staffed by lots of our liaison colleagues. But the idea here is that we improve the access, but also that we improve the experience of what it's like when you need to access that type of crisis care. There's lots more I can say about other different sort of bits of policy and maybe about the mental health support teams in schools, but we can maybe come back to that if that's of interest to the audience.
Thank you, Mary. And so encouraging to hear about that continuity of care, which then puts less pressure on the families to have to kind of piece it together. So that's very inspiring. And of course, the efforts you've just described go a lot further than those in many of the other countries represented in this room. That said, there are critics, and of course, with the NHS, there are always critics. And so I just wonder how you would respond to some of the criticism that is waged against some of these fantastic efforts.
Yeah, we're not nearly good enough. I mean, it's just, you don't need to qualify it. And I think, we can say, I don't think there's any country, from my perspective, that yet has got this sorted out. Yeah. You look at the decades of structural underfunding in mental health services, the structural underfunding in terms of research. There was an article that caught my eye a couple of days ago by a sort of a research institute sort of saying, our treatments in mental health are old-fashioned. Your choices for mental health treatment are medications we discovered about 50 years ago. It's different types of therapy. Yes, we've made some progress, but that's not because we've sort of not been sat around thinking about it. It's because we haven't had parity in terms of the research funding that's gone into mental health compared to where it has in other areas. And that maybe goes back to some of the things that you're alluding to, Rebekah, that the problem we sit with, it doesn't all just stem from politicians and so on. It reflects public choice. There's a guy that I always find very inspiring, and he always says, tell me your priorities. And then he says, I'll show you them. It's where you spend your money. And that's what we sit with in mental health. Half my week I work as a jobbing clinician. I'm a liaison psychiatrist. I work in a very busy emergency department in Southeast London. We do our best, but my goodness, we are not resourced to do what I would like us to be able to do. So I would respond to that to say, yeah, I totally agree, and we have to keep fighting the fight, advocating, developing the evidence, and demonstrating that we need to do more to improve access, experience, and outcomes in mental health.
Thank you, Mary. I want to ask about the challenges to access. Mina, what do you see are the biggest inequalities in the system?
So this is a massive area of interest, I think, for both of us. So I would happily talk for 4 hours for you about this, but I'll limit myself to 1 or 2 points. But it's been a massive area of our research and study. And it's not just about having access to services. What we see with especially the young population, and we've now asked 130,000 young people about this, some of the biggest barriers to accessing care are also about trust in the system. So if you think about an adolescent, they're struggling with normal development of normal processes of being private, not wanting to share. And then they might go and tell a teacher whom they do trust, and then they don't know if the teacher's going to tell every other teacher in the school and their parents. And so this is coming out more and more about one of the biggest barriers to accessing care is not actually trusting the system that is, mandated to look after them, because actually they don't know who's going to know We don't give young people autonomy. So I'm very interested also that we think about that, how do we make what we offer acceptable to the person that we want to reach? And the best way to do that is to learn from them directly. Well, why are they not accessing care? And then really thinking with policies. So I'm working a lot with medical lawyers, with ethicists as well, to just try and address some of these structural barriers as well.
Thank you. And Rebekah, at the Priory, how do you address inequalities to access?
Yeah, I'm just going to throw a few facts out there, which I think you ladies probably, and gentlemen in the audience probably realize, but globally, mental health affects 1 in 7 people. You've said some stats. It's a business decision to make sure we break down these barriers of inequality for people. It apparently costs $1 trillion in productive work, just not addressing people's mental health issues. So it's not just the right thing to do. It's good commercial business economic sense to address mental health issues. 1 in 3 girls 17 to 19 in the UK will have some form of mental health disorder, which you guys know. So what are we storing up for the future as well, for the future of women who are greatly represented in this room? So for me at Priory, we do pay attention to things. If you're black in England, you're 4 times more likely to be detained under the Mental Health Act than you are if you're white. We're doing a lot of work on addressing patient and carer inequalities and making sure that everybody's treated in the same way. And fundamentally, how we address this at Priory is seeing each person as an individual. We have a whole person care model. And if you do that, you can address some of the other inequalities because you're seeing the person and how they want to be treated, and builds on that trust that Mina was talking about. And the last fact is mental health is about 20% of the NHS burden, and yet they only get 9% of the budget. It doesn't make sense.
Wow. Wow. The case for the business case. Yes. I have a question for all 3 of you, actually. Increasingly, of course, AI is being used as a tool to assist in both improving mental health outcomes and also access. What are the most important and effective ways that you see this contemporary technology in deployment? But also, of course, what are the limitations? Perhaps I'll start with you, Mina.
We've actually been doing quite a bit of research on this. We've been asking a lot of young people. So with every wave of technological development, be that websites and then apps and then everything, everyone thinks this might be the panacea that we've all been looking for to address the mental health gap. And time again, it doesn't really seem to be there. So I think AI is being used. It's being used in quite interesting ways. I say interesting in the broadest possible interpretation of interesting. I think my take home is that maybe it might be a co-pilot, it might facilitate with some access, but we've been very clear in our survey. We ask young people, what would you like for more mental health support? How would you like to access it? AI and the online technologies are the lowest on the list. It is incredibly clear that overwhelmingly young people, and I think all people, are seeking the in-person mental health support by far. So I think that we can't ignore AI. They're definitely using it, but it's unlikely to be, there's no indication right now that it's going to be replacing actually what we all know deep down is that kind of often the informal networks of care playing the biggest
Real
role.
Connection.
Yeah.
Real connection. Mary, what are your thoughts?
Yeah, my priority for it is for it to release time to care. So release time for our clinicians, our therapists to be with people. I really upset my medical directors a little while ago because I said, look, this is AI, AVT, this is brilliant, we can see twice as many patients. And they said, oh, we could go home on time. And I did think that was an important bit of feedback in a then leadership role. But I do think that there is... Mental health is one of our most sort of paperwork-heavy, administrative-heavy sectors. the ability to release clinicians from typing things on computers and get them out there with their patient, I think, is enormous. So I think there is a great potential to enhance what we do. I'm absolutely sort of with Mina that I think we keep saying, well, young people want all these different options and they definitely want the access a bot, not just a human. It's very helpful to hear that the research is telling us that that isn't what everybody wants. So my priority absolutely sits behind how can we use this incredible technology wisely, with the primary aim of releasing time to care, with enhancing what we do. But I think before we move to that, we've got some really big priorities in mental health, and that, from my perspective, is the priority of ensuring that the people we're here to serve are supported in their digital literacy. We have enormous risks for people living with mental health problems if they don't have a decent understanding of the sort of stuff that is now out there. It's enabling our staff to have time to actually kind of experiment, to go, what is going to help? What's actually going to enable me in my role? And to govern all of this very, very carefully with the ethical and the legal frameworks. We work with populations who can be more vulnerable than others. Certainly working with people with learning disability and autism, and some of the challenges around, do you know what we're doing with your data? Are you really consenting? All these types of things are much, much more prominent within mental health than potentially in other sectors. So I would say my kind of overall approach to it is we need to show a huge curiosity, applied wisely, but tread very carefully.
That was clear. Thank you, Mary. Rebekah?
I agree with everything that Mina and Mary have said. I'm going to look at it from a slightly different angle, and we have saved hundreds of thousands of hours by doing some of the systems to release time to care. And we don't reduce staff as a result of that. That's just better connection with patients and residents, like you say, who we are here to serve. So I like the apps that really help the patient with their clinical pathway. So we've got a few of those. We use virtual reality for our addiction model for exposure therapy to help people go into different environments where they might have access to a substance or alcohol again, and we monitor their heart and their eye reaction and see, does the stimuli reduce over time? So that's really important. We're about to start looking at that with helping people with autism go out into social situations as well. So that can be a really helpful way of safely, with a therapist, they're not in there by themselves, exploring it. And another really great one, I'm a health visitor by background, and we have this Recovery 360 for alcoholics that once they've been through our program, they can be discharged home with the app. And there's a Bluetooth connection that they can plug into the phone. The app sort of asks them questions each day. A therapist is back at Priory monitoring that and can look for red flags so that they can phone somebody up and say, are you struggling at the moment, to avoid a readmission. And it also has a breathalyzer on it, and you can't cheat because it takes your picture while you're blowing into the thing. And one really great example of human thing was there was a gentleman who was losing contact with his kids because he couldn't sort of stop drinking, and people were, the trust goes when you have a substance misuse or an addiction, you know, and they couldn't trust him. But because of the app and him being able to prove that he was sober and able, he was still able to see his children. So that is wonderful. Exactly where you can extend technology.
Yeah, fantastic. Thank you. And some very concrete examples there, which is super helpful. The theme of this session today is how we improve the system through leadership, policy, and research. Mina, where do you see the biggest disconnects among the three, and how can we improve coordination?
I found this quite a difficult question, actually, and I've thought about it quite a bit. And I think policy is a responsibility of all of us, isn't it, to shape and make sure. So what then becomes the role of research in this? I think research has, access to data, processes to analyze it, and I think it's a bit embarrassing as a researcher. If you knew the inefficiencies in the research system, you would be really concerned, because we actually, as researchers, are spending so much time chasing funding in really inefficient ways that, I'm currently sitting on a big independent review that's been called by the government. I'm sitting on data that they need. I've got 130,000 responses of relevant stuff, but we actually don't have the researchers able to look at it. That no one's going to fund people actually making research more efficient. So I feel that thinking about this, I was thinking that, we just need to be aware that how can we think in organizations about how to make best use of research? How do we enable sustainability? We in research have extraordinary talent that we're losing because the structural inefficiencies and not investing in research means we're losing the brains that I think can answer a lot of the questions that we're grappling with. So I suppose I just say a little bit of frustration that, there's so much opportunity, but I think in research we probably need to learn from industry as well. The inefficiencies are just embarrassing.
Yeah. And perhaps another use case for AI and agentic technology to help digest all of the data.
The humans, but whatever.
Another key tension in the mental health system, of course, is how we balance the acute crisis care with long-term therapeutic support. Many systems are responsive, as we know, in moments of crisis, but are far less equipped to provide the sustained care that prevents people from reaching crisis in the first place. Rebekah, how do we begin to rebalance the system so that we're not only intervening in crisis, but investing in this continuity of care?
Can I answer this from a very practical
We like practical.
that we can all do? And it's being vulnerable ourselves and talking about our own struggles as women leaders. If we can be authentic and talk about mental health, that gives other people permission to do it as well. I mean, it just makes sense to me. I mean, my father died of cancer when I was sort of 23. I knew that would be a life-changing. I went to counselling before he died. I went to counselling after. I didn't wait to be depressed. And I think because I went to an American boarding school, it's just much more acceptable.
Yes.
In the UK, it was like, you went to counselling? Are you like I was mentally ill or something?
No.
But I saw it as a preventative issue. This is going to be really hard on me. So I need to go and get some help. It just made practical sense. And I share that with people. When I got divorced, I did the same thing. I didn't wait to fall. I didn't stop going to work. I just knew that I'd need help. So I think if we can sort of demonstrate that in our own lives. I've lost the question that you asked me, though, which was about how we rebalance the government. So how do we rebalance? So it starts with us at home and in our workplace and how we lead people. And it also, I think Mary's talking about community care. How do people like to connect? Maybe if things aren't too bad, a social app is a really important thing. I hear my 20-year-old son talking to his equivalent of, ChatGPT. He goes, "Thanks for that, Paul. I'll be back to you in a minute." And it's kind of like, how are we shaping things around helping people sort of fill up their cup, if you like, when it's running low. In many areas of life, which I think will go a long way, and that connection with people that Mina was talking about, hugely important.
That really resonates in all of our responsibility to reduce the stigma associated with talking about it. Thank you. Mary, you've talked about the challenge created by the shortage of mental health professionals and the emotional load of their work. Can you talk a little bit more about the NHS's long-term workforce plan and its role in addressing this issue?
I mean, I can't because it's not published yet.
Did I not say we're Chatham House?
I've got the hardest question.
But I can talk about what I think is important with regard to workforce. I mean, I'll say one thing that actually what we have prioritised in this country, and it's relatively impressive. There was in the government's manifesto a commitment to significantly increase the number of mental health professionals, and they've actually way ahead of their target in terms of 8,500 more mental health workers being recruited. But if you said to me, what do I think about our workforce? Where mental health is, I think, different from pretty much any other clinical specialty, it is about you as an individual clinician. You are the instrument, you are the tool to help that person. So the necessity of looking after that person who is tasked with holding the hopes, dreams, worries, fears, psychosis of another is extraordinarily. You don't look after that tool. Think what actual damage it could even do if it's not looked after properly in its act. So I really think the most important thing with our workforce is how we provide the space, the containment, the support for people who are engaged in therapeutic work, to recognize how it is impacting them, to think about and process the feelings that come out of having these, extraordinary therapeutic relationships with people, and are supported in their work. Seeing 5, 10, actually we can see 5, seeing sort of 15 people a day, those 15 types of interactions, they're enormous. How do you even know what's going on in each one? So I think there's a priority to look after the workforce. I think there's one other thing that I think is probably sort of, the most important, and where if I had a strategy I would be focusing on. And that, I think, is the skills. Something that I think we've set ourselves in it's not a particularly helpful direction is the failure to equip mental health workforce with physical health literacy. Yes. There is a staggering amount of mental and physical morbidity. The mind and body is one. So I don't require the mental health workforce necessarily to be able to, be up to a nursing level, but I do think basic literacy about the risks of cardiovascular disease, respiratory health, and so on, the ability to speak confidently with someone and educate them and deliver some basic health promotion is so important, given we know the sort of 15 to 20-year mortality gap for people living with serious mental illness. So if I was designing a workforce strategy, there would be 2 components in it. One, how do we make sure that we support our staff to be the most effective in their role? And then secondly, how do we make sure that they have the skills that actually reflect the population need, which includes physical, not just mental health?
Thank you.
I don't know if it's too late for me to get it in, whatever the writing.
Wonderful. Well, I think we actually have time now for audience questions. And the first one we have is from Christine Brown-Quinn, IWF UK. How do you define what is a mental health issue? And perhaps, Mary, I'll start with you on that one.
So my job as a psychiatrist is to work with mental illness. I would hope as a psychiatrist I would contribute in the community supporting overall mental health. It's not about illness, it's about your overall kind of emotional, psychological functioning. And I think where we've started to get muddy, and it's always been muddy, we can't pretend it's just a thing of today, that there is a spectrum by which distress moves into disorder. To me, there's huge discussions about this. It's absolutely, can actually be quite a polarizing thing, particularly around sort of certain changes in prevalence of certain diagnoses at the moment. To me, it's my business as a doctor, when whatever is going on with your mental health is fundamentally getting in the way of you living your life, when there is a significant functional impairment with what goes on. I think it's relatively easy for me as a doctor, especially a secondary care doctor, which means I'm not actually sort of managing primary care issues. It means that when people are actually sort of really quite sick, they come to me. But I would say that that is where we start to define, we could talk about this for about at least 5 hours, but from my perspective, that's where I start to define what's my business and what's less my business and more the business of sort of, society and community.
Thank you, Mary. The next question I'd like to hear from both Mina and Rebekah, and it's from Susan Young, IWF UK. Please, can you address the importance of the arts and the impact they have on mental health? Who wants to start?
I'd be very happy to. It's fundamentally important, isn't it? So what we try to do is put the kind of evidence base around it. So which arts in which way? So we talk a lot about bringing the arts into the therapeutic space. We've been recently thinking about, bringing nature into the therapeutic space as well. And a lot of that is artistic beauty of bringing the outside in. We've got a few studies now on using dance as a therapeutic technique, bringing in the whole creative art. So I think what we need is the evidence base to confidently say for the, there's no doubt the arts are very important, that the expressive, creative tools have been there for millennia to help us kind of make sense of the world and make sense of our inner life. And we're more and more now getting some of the evidence base to be a bit more confident. So for kind of depressed boys, this might be something to consider for that. So we want to be a bit more precise to learn where might it be most effective as well. So I think it's a good time for us to be learning more about the arts.
Thank you, Mina. And Rebekah?
I think for me, medication and treatment when you've got a mental health problem is only one slice of the pie. It's important, but it's one slice of the pie. And what I say is you need to, when somebody comes through that door, it's as important to give them hope than it is just a medicine. That is as important at the beginning, because especially if somebody's contemplating if they want to end their own life or something like that. So hope is a very key thing in treating mental health. Telling people you feel like this now, but you won't feel like this forever. And I think arts, whether it's music, dance, painting, we offer a lot of choice of activities at Priory. It can be equine therapy, it can be so many different things. Is all that beauty gives people hope.
Yes.
And it gives them another way of channel. It allows them to see light and beauty when everything feels quite dark. So I don't have any research that I can quote, although I'm sure there is some, like Mina was saying. But, you know, that to me is what the arts do for mental health, provide some light and hope in a dark time.
Thank you. And an ability to express oneself as well, which is so important.
Yeah.
The next question comes from Suzanne Garber, IWF Philadelphia. And Mina, this one might be one for you and tap some of your experience around refugee well-being as well. So, you know, access to care is difficult enough in developed nations. What is being done to make mental health care available to those with unstable physical infrastructure and connectivity in less developed nations?
Yes, it's a really important point. There's a big movement for many years about, you know, no health without mental health, thinking about these contexts. And I was just saying before, I'm going to Cape Town next week and bringing the voices of children from 19 different countries in the world to think about their mental health needs and the role of schools, for example. So I think what we're trying to learn is that, especially for adolescents, like, we're never going to have the mental health infrastructure in the vast majority of the world where the vast majority of children are. Like, over 80% of the adolescents in the world right now are in low and middle income countries. So what do we do? How do we pivot? How do we learn? And that's why I focus on schools, because that is an institution that is available throughout the world. What do we understand about that context? How can we make that context much more able to address the mental health needs of that population? So I think we can't just think about putting a system in. We actually have to think about unbelievable systems already existing. What do we do? How do we support that? Obviously, we don't want teachers to be doing the mental health. We need to be thinking about how, as institutions, we pivot to make these existing frameworks in these nations also able to address that broader need. So it's a massively important question. Thank you for asking for it and keeping that priority in our minds as well.
Thank you. Right, so I'm watching the clock. We've got 2 minutes, but I'm very excited about my last question because, of course, we've got 750 amazing leaders in this room, and we all want to take something practical back with us. So my one final question for each of you is, what is the most important thing we should do in our personal lives and in the leadership roles that we hold when we see someone who's struggling? Who wants to start?
I'm happy to start.
Go for it, Mary.
I'm going to give you 2 things. First, I'm going to give you the prevention thing to stop as many people struggling, and that's make people bigger. I see the job of a leader is to lift people up and make them bigger, and I think there's a lot in this world at the moment that is about making people smaller. So practice prevention. Those who you encounter, make them bigger, lift them up. 2, if you see someone struggling, say something. That's all. Say something.
Yeah. I would say don't walk past it. Don't ignore it. Be vulnerable yourselves and show them that it's okay to talk. And I guess sometimes acknowledging that that's not the right moment sometimes, but let them know that you're available when they are ready.
Thank you, Rebekah. Mina?
Yeah, the same. Like, don't be scared to say the wrong thing. We see it time and again. We have children who wish that their teacher would talk to them and say what's wrong. But we've got the teachers thinking, well, I don't know what's going on. I'm going to say the wrong thing. I don't want to open a Pandora's box. But that person might have been the only individual that child would have trusted. That's the same in the workplace. That's the same in the community. And so I think I would say, please don't close the door. If you think someone is struggling, speak to them about it. It's okay if you don't know what to say. Just acknowledging it is a really important first step.
Thank you. Mina, Mary, Rebekah, thank you so much for sharing your insights as we go and lead in our organizations. And for the audience, I'd ask that you please stay seated. Our next session will begin very shortly. Thank you.